Begin. So I have a fair amount to go over. Here we go. All right. So today I'm focusing on electrocardiograms, and I'll start with this. This is I start with this with the other groups. I might as well. No brilliance on my part. One day when I started to teach this unit years ago, I googled about information about reference for electrocardiograms, and this ECG library came up, and I looked at the site. It's a really good site, depending on where you're going with your careers. Understand that if and this is a very good frame to start it. Why this is important for any of you going into healthcare careers. If you're going into nursing, as a fair amount of the students are, and you want to work critical care, ICU, CCU, neonatal, operating room, recovery. There, what you learn here is insufficient. You're going to have to get vetted or certified by the facility. This is what UPMC does, and they were doing it 20 years ago. I assume they're doing it now. You go in and you have a week course. Okay? My ex did this 20 years after she got her BSN and went back to work in Shadyside, is now in the outpatient unit at Shadyside Hospital. She went over to Montefiore, and you go there 8 to 5, Monday, Tuesday, Wednesday, Thursday, homework every night, questions to submit, answer and submit. On Friday, you have a mega test that you have to pass in order to be able to work those units. It's not like, well, I want to work there, I'm going to work there. It doesn't work that way. Critical areas, they have to vet or certify or at least do due diligence to make sure that you have a minimum degree of qualifications over and above. That's why this stuff is important. Not that you're going to have to know this now. You just have to know the basics for me. But down the road, this is an important area for many of you if you're going to consider qualifying for and participating in a field like that. That's the jump off point. And there's plenty of them. She had to do that. And then the week after that, she had to do a whole layer of certification in cardiac meds. So, there's what to do, to understand these things. Again, this is at least 20 years ago. How it's changed for now. Do they do it online? Whatever. Who knows? I remember driving her every day because I was just part-time teaching. 7:30 in the morning, going down by Pitt, picking her up at 5. See you later. That's how I do it, and help them with the homework every night. So basically, what you can learn from this is the typical electric. We don't rely on them quite as much as we used to. We have tests that really can determine these things relatively quickly. But years ago, you had to do all of this, and they have a cardiologist would be reading these and generating a report. Now they report them by way of, they use AI programs. Sometimes they're a little scary. It happened to me. I had one from one year to the next when my physician would say, "Oh, let's get another EKG," or I have one done for a procedure, and all of a sudden it says no change from last year. Well, that was good. That was the bottom. The top one said consistent with findings of a heart attack and such thing. I went, what the? I went and started yelling at him. I go, what do you mean I had a heart attack? He goes, no. He says, it was no change from last year. You didn't have a heart attack. These are machine read. This happens to us too often. And when they're machine read that as AI read, more prone to error. So I had never had one. Hopefully that will all continue. Sorry, I'm not calling anybody, but if I was, that would be a reason to do it. But things like that are scary. Effectively, you have classically the 4 leads we call the limb leads. Back in the day, you put them on the wrists and the ankles, and that was what you would record when someone would come into the emergency room. Okay, we were still doing that kind of stuff. Only years later did we start to have those 4 pads that you just had to put, basically, as long as you put them around the heart, this on top, on one side or the other, on the bottom, one side or the other, snapped in the leads and hooked it up to the machine, you would see it. You won't have to, most of the stuff you'll be able to see. You'll see a patient on it. You'll see a monitor with a continuous display. It's nothing unusual, but effectively, those 4 leads, as you will see, generate, we don't use all four of them, we use three. They generate a series of triangles. And so the leads have three different names. This is just a generic tracing that maybe you would utilize to sort of get an idea of what's happening. But the leads are named 1, 2, 3, AVR, AVL, and AVF. Those are the limb leads. In a 12 lead EKG, which is the typical one that's used to be read, that I would have before an operation or every other year or whatever my family doctor wanted, you have what are called precordial leads, where they put them around the heart at specific areas, typically where there were valves or different structures that you would be isolating. Okay, and they have different names: the V1, 2, 3, V4, V5, and V6. So this is an example of a normal tracing. What we'll discuss today is basically each of these little squares, each of these big squares represent a fifth of a second. So each of those little mini squares in there are 0.04 seconds. It's a very easy way. Look, your heart's supposed to beat more rapidly than once a second. So this, but not excessively so. So look at this person. There's roughly 4 big squares. So that's 0.8 of a second in between beats. So probably they have, somewhere between 70 and 80. Would be perfectly normal. And you can see all of these more or less identical. Remember, it's a system. Any movement will come. That's what they tell you to lay still. You have what's called a P wave. We'll get back to what it represents. A QRS, the big spike, and then a T wave. Then a break. Then we do it all over again. And if you count the distance between the spikes, the easiest way to do it, you count the number of squares. And this is something you might learn to do, even though up on that monitor, it tells you what the heart rate is. It tells you what the blood pressure is. That's free. It tells you what the pulse ox is. But I now technology, but you understand periodically there are days when the technology goes down and you have to do it the old fashioned way. It's like when your computer breaks, it's like when our system goes down. Oh my God, there's no Wi-Fi. The world's coming. That's the problem with technology. You become so much a slave to it, you don't know what you're doing. It's like, oh my God. So that's sort of the jumping off point for this to explain this kind of thing. So what's nice about this is it even explains to you the whole idea, what's called the electrical axis. Basically, you're getting action potentials generated around the heart. And if you look at, remember 2 of those leads 1 and AVF, if the QRS are both positive, so if those spikes are going upward and lead 1 and AVF, that we can basically say that the heart represents a normal axis. If you think of where the heart is, where should be the biggest beat coming from? It'd be down low like this, that side of your chest. Look at the graph. This would be where it should be coming from. Okay, if it's busier on the right or in this upper left area, it suggests something's wrong. If it's way opposite, it really could be something wrong. And I didn't know about this. I actually, when I was a student, we hadn't learned about this. I wouldn't have learned about this until I was a resident. One of the medical students, I was still a student, one of these young folks who just graduated from Medical College of Virginia, where I was doing a summer program, takes out a little notebook, and I go, because we're looking, because he had to interpret the EKG and present the case to the attending. That's what you do. And hopefully you get all the stuff right, or you're going to have a very unpleasant day after that. And I go, what are you doing? Oh, I'm looking at the electrical axis of the heart. And he starts showing me this, and I'm like, really? And I get out my little notebook, and I start writing stuff down furiously. I had like a series of spirals. I'm playing sponge, absorbing all this stuff. And he goes, oh, no, if you look at 1 in AVF, I'm like, really? That's pretty interesting. So what if it's not there? What if it's way up here? Well, I mean, you may have very well just put the leads on backwards. Hey, first thing you do when something looks funky, out of sorts, check to make sure you put it on the right way. That's the easiest thing. I mean, we all make mistakes, make little ones. Rather than, oh my God, we have ventricular tachycardia, or somebody's potassium is way up, something like that. They could have emphysema. Typically, right side of the heart is enlarged. Typically, that's chronic lung disease. pulmonary embolism. I mean, those are the kinds. So this is broad brush stuff. If it's on the left, now you start looking at typical myocardial infarctions, heart attacks. Those are the kinds of things. But it could be almost anything. So you have a lot of overlap with these. But it gives you an idea. And what's nice about this particular, down the road, if you want to look at these, you can actually look for, they will have 12 lead EKGs with patterns. So down the road, write that down. If you feel like it, go back. And you could easily find, just Google ECG library, you'll get all of this stuff. So that's where we kind of begin today's presentation. And so while I will use the other PowerPoint, this particular PowerPoint from the Welsh whole text kind of shows you this a little bit. And it talks about the sequence from the SA node and talking about the fibers, basically the AV node, the bundle, the branches, what I will call Purkinje fibers, and eventually how this impulse travels. But I'm not going to go through all of this here, but this is a good summary, a recording of the electrical changes that occur in the myocardium, in the heart muscle. Pardon me, I keep looking for a text. Okay, that occur in the myocardium during the cardiac cycle. Eventually, what we're going to go is we're going to look at the cardiac cycle and marry it, all the pressure and volume changes, and we're going to marry that to heart sounds, and we're going to marry it to the electrocardiogram. And that's really one giant slide will explain a lot about, really will assist you in understanding a fair amount about the heart. That's the beauty of when you have a really good illustration or graphic. So we use them really to assess this. Deflections in the normal electrocardiogram, and I say EKG, so if I say it, don't be confused. They're both legal. Okay, the P wave represents atrial depolarization. Electrical events precede mechanical events, which happens just before the atria contract. That giant QRS, that big spike starting going down, then up, and then down again, is ventricular depolarization. Yes, right before contraction. The ventricles are so much larger, they obscure the atria repolarizing. And then the T wave, again, ventricles are very large, are the ventricles repolarizing, and obviously that occurs right before they relax. So, and that's all very, very accurate, that part of it. Why do I frame it this way? And I'm going to go, but that's that illustration that down the road probably we'll get a good look at on Monday, where I think it's really important. And where am I going? Up here. So we'll take a look at this. Why is it so important to understand that? I mean, I think they're still outside on the wall. They have it, and you'll see them all over the campus, at a mall, certainly in big buildings. They have AEDs, automatic electronic defibrillators. You've all seen them, I'm sure. Years ago, if there was a witnessed cardiac arrest, in other words, you see somebody in the hallway there in a mall, all of a sudden go, oh my God, down they go, heart stops. That's called a witnessed cardiac arrest. And let's say you know CPR, and you're there, a couple of other people are there, whether it's one or two or more people. The odds on successfully resuscitating that individual, 85 to 95% if you start CPR right away, which is very good, but not great. 5 to 15% of people are going to die. Look, face it, some heart attacks are so massive, it doesn't matter what you do. They found statistically, and most of this was done with the health department in the state of Washington, which is really where CPR had its origin. You go back and look historically. They found that if it was a rhythm that required defibrillation, what we call a shockable rhythm, you could increase the success rate to 95 to 99% by defibrillating early. That's a massive impact. Now you're 5% or less of the people succumb, and probably the people who are succumbing are the people who are going to succumb anyway, where none of your efforts. That's why, and anybody can use those. We have computer technology in them assuming, and they're checked regularly to make sure they're powered up. You just put them on. They'll show you what to do. Anybody can do it. You don't necessarily have to have, and you can defibrillate. And certainly, some of you are or will be or previously were trained in CPR. I'm sure, and if not, believe me, when you're that's part of the deal in the hospital. I haven't upped in CPR since probably mine expired in 2002. I think they're 2 years. And the last time I operated in a hospital was probably at the end of 2000 because the hospital closed and it got torn down and became PPG Place. Not PPG Place, PPG Event Center, the old console center where the Penguins play. Sorry. So that was the last time I operated. I operated out of that hospital for 10 years. So all that is really sort of the background for why we have to know about this. Let's look what happens with regard to this. So this is basically just showing you it's different. So when you talk about pacemaker potentials, it just means that what we're going to talk about, this first item, the SA node, has very leaky. Once it goes down to resting potential, it has these very leaky sodium channels, and they will immediately start to bring it up to threshold at a predictable rate. It's not a typical action potential because it involves calcium more than it does sodium in generating the action potential. That's of note, but not a major issue. So it's not that typical sharp spike we're so used to seeing. It really, the whole series event of this electrical activity takes less than a quarter of a second. What you will see, at a minimum, the heart will rest. It will not reset and be able to fire electrically for another, at least roughly a quarter of a second. We call that the absolute refractory period. It's due to those inactivation gates. You might remember from earlier when we talked about muscles and nerves and AP1. They are there. And that's really important. What it does is it prevents the heart muscle from spasming. Someone may say, oh, I had a heart spasm. It doesn't happen. They may have chest pain. It may feel like a muscle spasm. It's not like you and I getting a Charlie horse or a muscle spasm. The heart muscle can't do it because it has that prolonged absolute refractory period. And it limits how fast your heart can go. There's a maximum heart rate. So, but by and large, your maximum heart rate, I think, is, you have to know the number 233. What they basically tell you to do, like when I was, on the treadmill last night again. Okay. I mean, they tell you, start with 220, deduct your age, and take 80% of that, and that's your target when you're doing aerobic activity. So even though I'm a little older than that, so 220 minus 70 is 150, 80% of that is 120. My target is between 150 and 120. And really it's important for all of that, for you folks probably not, for me, for people 30, 40 and over, start doing it now. So you have to try to get, and it's a good measure. When I first started doing it, when my wife dragged me kicking and screaming back to the gym, it was like, it jumped up right away. Now, I mean, it took me a good last night, 5-7 minutes, gradually increasing the elevation of the treadmill and the speed for me to get up to that level. And that's a good sign. You want that to happen. The boss. Because there's something we're doing. If it is, hold on. So, I mean, that's why this is such an important thing to understand. My car is sick and has to be towed, and my wife has to take care of it. And this is what she's talking about. So I apologize for the delay. That's there. These are the things. So we want it to be at the SA node. That's got the leakiest channels. That's oh no. Should I call somebody before I leave here? No. Okay, boss. So the SA node has the leakiest channels. I apologize again for the delay. That SA node basically will generate a pulse typically around 75 beats per minute. If it doesn't, we'll see problems. That impulse in the SA node is located in the upper portion of the right atrium, will travel next of any relevance for us to the AV node. That's the area where the fibers are killing me. That's the area where the fibers are less abundant. They have less gap junctions. The signal is intentionally delayed there. The concept of the intentional delay is to let the atrium fill sufficiently. That's really the rate determining step. That takes up probably half of that 0.22 seconds. Half or more of that time comes from going from getting from the atrium and allowing them to adequately fill the ventricles. Once they fill, everything else happens super rapidly. They immediately go through the AV bundle. That's the only connection between the atria and the ventricles. If we insert a pacemaker, which is often the case these days, we don't use the medicine so much anymore. At that point, you have to actually put leads in the atria and leads in the ventricle, and the pacemaker serves as the connection. So, I mean, if the damage is there, it's really significant. The medicines they used to use are very harsh. Now, pacemaker technology has improved. I saw in the other group when my mom, when she reached 70 or 80, and when they were talking about, she heard about somebody getting a pacemaker. She said, "Don't let me have one. I don't want one." Because at that point in time, back in the 80s and the 90s, she said, people live for about 5 years. I'd rather not have one. If I'm only going to survive 5 years, I'll avoid the surgery. So I mean, it's really, there have been over the last 20 or 30 years, the technology has improved dramatically. There are still problems with it, but it's improved dramatically. And then from the AV bundle, it goes very, very rapidly to the bundle branches and to the Purkinje fibers, which this author calls the subendocardial conducting network. The Welsh whole text says Purkinje's. I learned Purkinje's. So it depolarizes faster. When we have that rhythm, we call it a sinus rhythm. What makes it a sinus rhythm is that you get a P wave representing the SA node and then a QRS. It doesn't account for anything else. Okay, what makes it a normal sinus rhythm? Normal is about frequency. So normal means it's between 60 and 100 beats per minute. Okay, so the terms are not equivalent. There's sinus rhythm and normal sinus rhythm. People mistaken, and I think this is something that you should be acquainted with, where you, particularly depending on where your career path is going forward. The delay is about a tenth of a second. It typically has been between a tenth and a fifth of a second, between 0.10 and 0.20. Somewhere in between there is about average. Again, thinner fibers, fewer gap junctions. This can take over. It would inherently beat 50 beats per minute. That's not enough for you to do any kind of activity. You would have to stop going up and down those steps to get up to this classroom. I mean, if you were going up the steps, you'd probably have to stop when you got to the top and say, "Oh," because all of a sudden you're not generating enough circulation to compensate for that. So these people become very sedentary, and it's going to shorten your, let's be clear, Dave, we're going to need a pacemaker. That's called a heart block. Some people will call that a total heart block. If you see, and you're going to see evidence of partial heart blocks and total heart blocks. So here are the bundle and the bundle branches, and then the Purkinje fibers. They have a beat by themselves of 30 per minute. That can't even sustain life. If the damage was such in a heart attack, that would lead immediately to irregular ventricular contractions, what we call VFib, and it ain't good. Then if you don't get that taken care of with defibrillating right away. And if something that can't be managed to some degree, either with surgery or a pacemaker, that person's not going to survive or survive very well. So here they're showing you the illustration, very similar to the one in the other textbook. They're just representing the SA node here. This is called the internodal pathway, not a big deal. It's just how the signal gets to the other atria. And here to the AV node, even though that really is in the septal wall. Here's that, the bundle or bundle of His is the name a lot of people still refer to it as, bundle branches. And so once it gets here, boom, it is super fast. And that's where you're going to see that dramatic amount of electrical activity, because it's shooting that signal rapidly all through the rest of the heart. So it's not just going side to side, it's coming forward at you, posterior. Think three-dimensionally when you think of these signals. I think that's important as well. So any irregularities we call arrhythmias, an irregular heartbeat. And it's very, very troubling. Fibrillations are the worst. If they occur in the atria, they will lead to the ventricles. If they occur in the ventricles, they eventually will lead to the heart not functioning at all. So that's one of those rhythms that those AEDs are designed to affect, fibrillations that are there. So effectively, the analogy is called a bag of worms. It's almost like we're fishing and had a bag of worms in soil, and they're all bouncing around. You can feel little impulses in no specific pattern, but not insufficient to generate sufficient circulation for the heart really to work. That's why it's so bad. And look, it's again, that's why we consider it a shockable or defibrillatable rhythm. And the whole goal of defibrillation is to fire all the muscles at once. They have to relax because of that absolute refractory period. And if you're fortunate, the SA node will all of a sudden go, oh, I'm supposed to be in charge of this. And it will start to beat the way it's supposed to. Whether it's too rapid or too slow, but at least we will convert that rhythm, and that's what it's called. We'll convert that to some kind of a sinus rhythm, and hopefully a normal sinus rhythm. And at that point, then you can start figuring out why it occurred, how you have to treat it. Is it medical? Is it surgical? Do they need a stent, etc.? All these things. The most common cause of death in the United States and indeed worldwide is heart disease. Okay? And in this country particularly, because we're too inactive, our diets are not good comparatively. We're alarmingly, hello, pot, this is Kettle, overweight. Don't you dare, because you're not. Erin's giving me a hard time. She always does. Just does. Okay, I'm a little chunky. Even the vet, I'm like the dog. She goes, you know, his weight, he should be about 68 pounds. He's 76. He's a little chunky. Okay. You know, you got to go work out. We're getting a doggy treadmill. Get to it. It's tough work sleeping all day. He has to sleep extra because he has to sleep all day. And he begs. So basically that's what happens. So an ectopic means not where it's supposed to be. It's not just about pregnancies. An ectopic focus is when you're going to see the example illustrated. It's called a junctional rhythm. It means that AV node, and so sometimes we call it a nodal, Nodal rhythm, because it took over. Not good. So that's somebody who's probably likely going to have a pacemaker inserted. Irregular heartbeats or premature contractions. These are more normal than you think. Most common thing that we see today, caffeine. Okay. Back in the day when we had more people smoking, as well as, I mean, was us where we survived on caffeine and nicotine, staying up all night, all that type of thing. Everybody's smoking cigarettes, drinking a ton of caffeinated beverages before energy drinks, and a lot. I mean, and so it's something that is probably more often associated with lifestyle changes, When it's something, when those lifestyle changes are not the cause, then you have to look deeper into it and see what the cause is. And so anything that blocks this, we call heart block. Partial means either the impulses are getting through inconsistently, or even though there's just a delay, it's longer than it should be. So it's not taking that 1/10 to 1/5 of a second it should be, it's more prolonged or elongated. A total heart block is that now nothing is getting through from the SA node, okay, and now that nodal rhythm has taken over. And you're going to see the illustration, okay, and it's too slow to maintain adequate circulation, and that's why we have to effectively recouple the atria and the ventricles. That's what they do. And so your sympathetic basically is there to increase your heart rate when necessary. What you want is the vagus nerve and the parasympathetic. That's the sign of your good health. Your resting heart rate, okay? I mean, you should be able to take it when you're relaxed, when you're sitting around, when you have anything to eat or drink for a while, and just randomly check it and just feel your radial pulse and your stopwatch function. If it's somewhere, and do it for 10 seconds and multiply by 6, if that's somewhere between 60 and 80, you're fine. And for all of you, I would suspect that would be much more than anything else. Okay. And if you go out and exercise or you're on a treadmill, test it again and see how rapidly when you stop, it goes back to that normal range. That's an excellent measure. It should take a longer time to go up and it should go down relatively quickly. That means your heart has a lot of reserve and it can compensate quickly. And so I was really happy on the treadmill. It was taking me longer to get up to that target range, having only been doing this for just a couple of weeks. For about 2 years, I did it regularly and then got out of the habit. And now that I lost weight, I should get back into the habit. So it's getting a little bit easier. Maybe I can shoot an 81 like my best friend did a couple of weeks ago. I told him that last night. I could shoot 81, then I have to play the other 9 holes. Very difficult. Okay, so it's mostly contractile fibers. This is how they work. So the signal you had involved calcium. The actual contraction, it's different. Good old fast voltage gated sodium channels. But you're going to see here, by intent, we want this contraction. It's not a skeletal muscle. It's a cardiac. We want it to last. So you start with sodium channels, then you have slower calcium channels. And then as you see, after about 200 milliseconds, the voltage gated potassium channels open and that resets it. This is it. So in skeletal muscle, 1 to 2 milliseconds. But in cardiac muscle, 200 milliseconds. Okay. And both the action potential and the contraction last for a long period of time. So we get a sufficient amount of blood into the heart where it's supposed to be and ejected. And that longer refractory period prevents tetanic contractions. That's why the muscle can't spasm. This is the absolute refractory period. So here in blue is the action potential. It spikes very quickly. That's the sodium. The calcium allows it to plateau and maintain that contraction to fill. And then you can see once the potassium channel is open, down it goes. And that roughly a quarter, not quite, but roughly a quarter of a second, absolute refractory period. Even after here, even though there's still a moderate degree of contraction, you have a relative refractory period. That's the beauty of the heart. So you can see the tension develops normally, but the electrical activity is really pivotal in understanding this, what we call absolute refractory period. It's so important. You must know about that. And so the electrocardiogram, typically you do this 12 lead you saw before. We're going to look at the P wave, the QRS, and the T wave. What's important and what's really important in understanding is that the PR interval, that's from the signal being generated in the atria and basically all the way until the signal starts going to the ventricles. It's the intentional delay that allows the atria to, what I call, top off the tank. And it should be between 1/10 to 1/5 of a second. When we start looking at the ST and the QT segments, then we're looking at the ventricular myocardium and how they respond, either depolarizing or repolarizing. That's very indicative of damage, which would mean a heart attack that has happened in the past or is happening right now. Again, we don't have to use these as much now. We have lab tests that can show whether a heart attack has occurred. We can measure troponin, and we know it comes from the heart because there's a different troponin than in skeletal muscle. There's none in smooth muscle. That will show it on blood test right away when someone comes to the emergency room. Years ago, we had to do EKGs serially, do different kinds of enzymes serially over 3 days. You'd have to have a person in for 3 days and all of a sudden, well, you didn't have a heart attack. What did I have? Probably indigestion. Maybe you strained yourself doing an activity, but you probably have to watch yourself. But that was, now that doesn't happen anymore. You just can't keep somebody in the hospital for 3 days. You can keep them, if you did not know, in the emergency room for up to, but not exceeding 24 hours, or it constitutes a hospital admission. There's all sorts of rules. That's what it looks like. Those are the precordial leads. This is the limb lead here, limb lead here. You can see where they put them on. Not great. But here, the PR interval, they're reflecting 4 of those little squares. So that would be 0.16 seconds, right in the normal range. So if it was longer than this, maybe even another square would be all right. But anything longer than that, between the start of the P wave and this very vivid, the Q goes down a little bit, the R goes up shockingly fast and goes down shockingly fast. That's the S wave. And this ST segment should be flat. It should be neither elevated nor depressed. Both of those signal irregularity in the ventricles. So those are the things you look for. And I'll show you some examples after we go through all those. So any of those patterns, if the R waves are too big, they should go up no more than 100 millivolts. Okay, that's really what it goes. When it's bigger than that, the heart is too muscular. Okay, it's typically a sign of cardiomegaly or an enlarged heart. Unlike working out, where you may want to build up your muscles to a certain point, it doesn't help your heart. Short term, maybe it does. Long term, just like any other muscle, remember, the muscles are overly contracted. You can't generate enough force. That's what happens. There's a point of diminishing returns. What causes it? High blood pressure, almost exclusively. Because if your heart has to constantly work against pushing blood against taut vessels, that's what high blood pressure is. There's too much tension in those vessels, hence the name hyper excessive tension. The heart can't push them apart. It's got to work overtime. And sooner or later, like any muscle working overtime, you're going to reach a point where it's going to be overcome by the battle. That's something we look like. And when we see either elevated or depressed ST segments, it typically means there's not enough circulation, or there's been an incident where heart muscle has died. We call that a heart attack or myocardial infarction. We're going to see elevation or depression of the ST segment. And when we see this QT interval, something you look for, when you see that whole repolarization, now you're starting to think about arrhythmias. Q waves are something, when they're exaggerated, very often you will see in an acute event. Maybe there's a heart attack in progress in certain leads. And again, I don't think it's something that you're going to be taught, but down the road, you're going to become acquainted with it, I think. And again, maybe you have to take these courses either on-site or online in a particular institution you might work at, etc. So here's normal. You can count the squares. This is roughly 17 to 18 squares between the R. It's very consistent. Each of these is identical. You have a P wave, a QRS, T wave, nothing excessive. 3 to 4 squares between the P wave and the R. That's a normal sinus rhythm. Sinus, because every time there's a P wave, you have a QRS. Normal, because it's roughly 75 beats per minute. It's between 60 and 80, period. Again, well-trained athlete, somebody, a young, healthy individual, maybe it'll be 55. That'll be normal for them. This is a total heart block. Why? There's no P waves. Notice how long the signal is between. This is a second. 1, 2, 3, 4, 5 full blocks plus more. You're probably at best 50 beats per minute. Somewhere between 40 and 60. There's no P waves. So only the ventricles effectively are contracting. Whatever filling is happening is in between beats, and it's not sufficient. Sooner or you're just not generating enough blood being pushed to your lungs or pushed to your rest of your body to sustain any even mild to moderate activity. So this is somebody who have to be by perforce very sedentary. So we have to reestablish the connection. That's where pacemakers come in. So that's a total heart block. This is a partial block. A partial block could be, and I'll go backwards, could be just as being elongated, okay, or it could be classically one of these second degree heart blocks. First degree would be just elongated between P to the QRS. Third degree would be that total block you just saw, the junctional rhythm. This is a second degree. In other words, every other one. And notice they're not pretty. P, QRS, who knows, way down. So there's a lot of irregularity in it. There's obviously been some damage down here. P, QRS, T wave, P, nothing. P, QRS, T wave. So every other one is getting through. Very elongated pattern. So that, again, that's another one of those where nowadays we don't use medicine, we use pacemakers. The medicines had a lot of side effects. And this is the very, very famous VFib. And because, I mean, it's chaotic. It's grossly abnormal. Perfect words. Acute heart attack. And maybe you were shocked in an electrical shock that was severe and caused somebody to go down. If you don't get that defibrillated soon, it's going to flatline. Once it flatlines, there's no electrical activity. So what they would have to do in an emergency room or in a code or an EMT getting inside, they would have to give them epinephrine, some way, shape, or form, and probably directly into the heart. There's other places you can inject, but you basically have to get some kind of electrical activity for an AED machine to really work efficiently. So if there's no electrical activity, you can bang that thing. It's unlikely it's going to give them any electrical activity. That's what I was taught. Maybe the machines are better today. But that's a very famous rhythm in and of itself. That's what I have to share with you today. We're done. So go on, have a great weekend, get done a little early. Why not?
Can you post that slideshow on Blackboard?
I certainly will. I use them and then I tend to forget them, but I'll get it all done.